بسم الله الرحمن الرحيم. في الأول أحب أشكر الأخ العزيز وزميلي الفاضل الأستاذ الدكتور أحمد عثمان وكل اللجنة المنظمة على دعوتهم الكريمة المؤتمر، ومؤتمر موفق وناجح بإذن الله. It's an honor to be present with my dear chairpersons. موضوعنا هيبقى عن pulmonary nodule follow-up clinical point of view. This is our objectives. Artificial intelligence زي ما يعني كيل سريعا it's a machine learning, the subfield of AI where algorithm can recognize and learn patterns using complex data. Deep learning can be identified as a class of machine learning where algorithms are organized into many processing layers. Finally, convolutional neural network similar to the human brain is a type of deep learning model most commonly used for medical imaging presently. سريعا, definition of pulmonary nodule, it's a radiographic opacity less than 3 cm in diameter with at least 2/3 of its margin surrounded by lung parenchyma without associated athlexis, while if it more than 3 cm in diameter, it's called lung masses and should be considered indicative of lung cancer until histologically proven otherwise. Most common etiologies of the lung nodule, infectious, either TB, it's most common, or bacterial, or fungal, or parasitic, or benign tumor, hamartoma, chondroma, or malignant, or inflammatory, rheumatoid arthritis, or sarcoidosis, or vascular, AV malformation, hamartoma, congenital bronchogenic cyst, or lung sequestration. This is some picture of different lung nodule and lung masses, more than 3 centimeters. Our problem as a clinician is for the detection of incidental pulmonary nodules has significantly increased over the last few years. Chest X-ray nodule, it's 1 to 3 centimeter, majority were malignant, while multi-slice CT 2 to 3 millimeter lung nodule, vast majority of small nodule are benign. Incidental finding dilemma. While we are doing a CT pulmonary angiography for suspect of pulmonary embolism, we have a double risk to find a new incidental pulmonary nodule or thoracic adenopathy than a pulmonary embolism. Also, in just over 50% of cases, those incidental findings are pulmonary nodule that require follow-up. Also, cardiac CT screening for coronary artery disease pick up pulmonary nodule in 5 to 20% of patients. And CT urography for hematuria, we discovered that 30% of unsuspected findings are incidental pulmonary nodules. Also, 20 to 50% of all smokers over 50 have at least one nodule, and less than 1% of very small nodule, less than 5 millimeter nodule, will turn out to be malignant. Once a nodule is identified, both patients and the clinician become concerned. We have two types of pulmonary nodule, either it's solid or subsolid. Solid nodule is the most common type, characterized by homogeneous soft tissue attenuations, while subsolid, it's either pure ground glass or partial solid or part solid. Pure ground glass, it's non-uniform in appearance with a hazy increase in local attenuation of lung parenchyma, not obscuring the underlying bronchial and vascular structures. While part solid is comprising both solid and the ground glass attenuation. Both components are present. Which nodule don't require any follow-up according to the morphological characters. Calcified nodules, as healed granuloma, for example, the different pattern is either diffuse or central, laminated, or popcorn, mostly benign characters, while punctuate or eccentric or amorphous calcification and are indeterminate patterns that could be malignant until proved otherwise. Also, the peripheral nodules, which is homogeneous solid nodules attached to a fissure with a lentiform or triangular shape, may be subpleural in position. It's not likely to be malignant, mostly benign, and also hamartomas. So what's the difference between different guidelines? The difference is the interval or total term for follow-up and the cutoff for nodule size vary between guidelines. The analogs between all guidelines, either ECCB or Fleischner or PTS or NCCN agrees that the initial evaluation should focus on appearance, either solid or subsolid, and the borders. Sequentially, the size and the risk or probability of lung cancer are estimated. These are risk factors that we should concern about it. Either the patient is current or past history of tobacco smoking, old age, occupational exposure to carcinogenic agent, previous history or family history of lung cancer, comorbid lung disease, and structural lung disease. So first is the solid nodule. According to the different guidelines, we have to decide firstly the diameter of the nodule. If it's between 4 to 6 millimeter in diameter, it's recommended for no follow-up for this nodule according to the most common 4 guidelines. If it's between 6 to 8 millimeter, it's recommended to do a follow-up CT after 1 year, 12 months, and an exit scan after 2 years. If it's more than 8 millimeter in diameter, according to the guidelines and according to the risk factor of the patient, is it low risk or high risk? But all guidelines recommending to do a PET-CT or a bronchoscopic biopsy for the nodule or a surgical excision according to the risk factors of the patient detailed for each patient. And the first follow-up CT is after 3 months if we have to follow up, not surgically excised. What about subsolid nodule, either pure ground glass or part solid? If it between 4 to 6 millimeter, either ground glass or part solid, no follow-up according to the commonest guideline. But if it more than 6 millimeter in diameter, it differs from is it pure ground glass or part solid. ECCB, for example, if it more than 5 millimeter pure ground glass, it's an annual follow-up for at least 3 years. If it more than 10 millimeter ground glass, early follow-up after 3 months, followed by bronchoscopic biopsy if it's indicated or high-risk patients, while part solid less than 8 millimeter, follow-up at 3, 12, 24 months, followed by annual CT screening. If it's more than 8 millimeter part solid, follow-up after 3 months. If it's suspected, we have to proceed for bronchoscopic biopsy or surgical excision. If it's more than 15 millimeter in diameter, just straight go to bronchoscopic biopsy or surgical excision after doing PET-CT. PTS, if it's more than 5 millimeter, either ground glass or part solid, no difference between both, just follow up CT after 3 months, then after 1 to 4 years. And if it's suspected in any follow-up stage, go directly to bronchoscopic biopsy or surgical excision. Fleschner, if it's more than 6 millimeter, ground glass, follow up at 6 to 12 months. If it's more than 6 millimeter, part solid, just follow up after 3 months to 6 months. If it's suspected, go directly to the bronchoscopic biopsy or surgical excision if it's suspected. So this is the summary of difference and analogs in subsolid nodule guidelines between all different guidelines. ACCB and Fleschner separate pure ground glass from subsolid nodule, whereas PTS and NCCN address all subsolid nodules as a whole. Cutoff size for no further surveillance is different, less than 5 millimeter for ACCB and PTS, less than 6 millimeter for Fleschner and NCCN. Duration of follow-up is different also. ACCB 3 years, PTS 4 years, Fleschner 5 years, and NCCN 5 years. So how to approach for the solitary pulmonary nodule? The gold standard is the CT transthoracic needle biopsy, but it has a different hazards, either pneumothorax, bleeding, nodule is risky, emphysematous patients, not accessible. So the idea is the bronchoscopic biopsy. Bronchoscopic approach for diagnosing solitary pulmonary nodule, either conventional bronchoscopic biopsy, if it's reachable. If it's not reachable, we have to do another advanced modality, either thin or ultra-thin bronchoscopy, image-guided bronchoscopy technique, either radial EPOS, electromagnetic navigation or virtual navigation, robotic bronchoscopy, COMPIM-CT, bronchoscopic transparenchymal nodule access and the transbronchial access tool. This device is called Archimedes. It's some types of advanced navigation bronchoscopy model called Archimedes, or a combination of many different modalities from the above mentioned. So what's the bronchoscopic therapeutic option for malignant lung nodule? It's including Bronchoscopy replaced the marker for stereotactic radiation therapy. Bronchoscopy guided ISAL, radiofrequency ablation, microwave ablation, photodynamic, brachytherapy, cryoablation, vapor thermal, and direct therapeutic injection, either chemotherapy or gene therapy to the tumor. Thank you for your attention.